Okay, so picture this. You get those lab results back from your doctor, just a sheet of paper, right? Full of numbers, weird acronyms, maybe some highlighted ranges. You look at it, maybe see a few things flagged within. What does it all mean? What if you could actually, understand the secret language your body's speaking through those reports? Today, that's exactly what we're doing. We're taking a deep dive into the fascinating world of laboratory values.
Yeah, our goal here really is to help you turn those complicated-looking reports into a tool you can actually use. We want to give you a shortcut, sort of, to being genuinely well-informed about the hard data, the objective stuff that paints a picture of what's going on inside you. And we're drawing all our insights today from a really comprehensive source. It's called Lab Values, Everything You Need to Know About Laboratory Medicine and Its Importance in the Diagnosis of Diseases by David Andersson.
And you'll find out some pretty surprising things about what those numbers signify, why they're just so vital in healthcare, and how they tell this crucial story about your health. Sometimes, even before you feel anything's wrong. Think of it as your body's silent storyteller.
It really is amazing how much medicine relies on this data. Did you know something like 60 to 70% of medical decisions hinge on lab test results? And that's not just for figuring out what's wrong initially. It's huge for tracking how treatment's working, tweaking things, even catching potential problems before they really take hold. These numbers are fundamental.
Okay, so let's unpack this whole process, because before we even get to the numbers themselves, the very first step, getting the sample collected correctly, that seems absolutely crucial, right?
Oh, absolutely. Foundational. An error in collection isn't just a small slip-up. It can genuinely put patient safety at risk or lead to completely wrong conclusions from the tests. Our source material highlight the common samples. Blood is the big one, obviously, but also urine, stool, mucus or sputum, pus, even cerebrospinal fluid. The main point is each one needs to be collected in a very specific way to make sure it's, valid.
So what are those critical pre-collection steps, the things that have to happen before the sample is even taken?
It really starts with the absolute basics. First, correct patient identification, making sure they have the right person, maybe checking an ID tag. Sounds obvious, but critical. Then, labeling. The container needs your name, usually an admission number, and exactly where the sample came from. Non-negotiable to avoid mix-ups. And a really important one for many tests is checking if fasting is required. Asking the patient, making sure they follow the instructions. Simple things, but they prevent major errors.
Right, and blood tests are so common. What are the different ways blood gets drawn and why the different methods?
Okay, so for blood, there are basically three main ways. The most common is a venous sample. That's usually from a vein in your arm, like the crook of your elbow. They use an IV needle, sometimes a smaller butterfly needle if veins are tricky. The key is a clean draw, getting enough blood without damaging the cells. Then you've got capillary blood. This is what people often do at home, like diabetics checking their glucose with a finger stick. You typically use the side of the middle or ring finger, wipe away that first drop of blood. That's important to avoid skin contamination, and then collect the sample with gentle pressure. No milking the finger.
Okay.
For newborns, it's often a heel stick, similar principle. Warm the heel, quick puncture on the side, wipe the first drop. And finally, there's arterial blood. This one's more technique sensitive, usually done in hospitals, often for emergencies or checking respiratory status. It's drawn from an artery radial in the wrist, brachial in the arm, or femoral in the groin. Requires a specific angle, a heparinized syringe.
Heparinized, to stop clotting.
Exactly. Arterial blood clots fast. You'll actually see the blood pulse into the syringe with the heartbeat. And it's critical to get it on ice immediately and analyze it within about 10 minutes. Plus, careful monitoring of the site afterwards.
Okay, that makes sense. What about other common samples like urine and stool? What are the key things there?
For urine, if you're not catheterized, the goal is usually a midstream sample. So you start urinating, then collect the middle part of the stream. This helps flush away bacteria from the urethra.
Right. Avoids contamination.
Precisely. For some specific tests, like certain pregnancy hormone tests, the first morning urine is best because it's the most concentrated after sleeping all night. If someone has a catheter, there's a specific port on the tubing used for sampling after cleaning it carefully. For stool, hygiene is paramount. Gloves, maybe an apron. You collect it into a clean container, like a bedpan. You need about 10 milliliters using a little spoon usually provided. Get the lid on quickly, and often note the color and consistency. The main theme is always a clean, representative sample.
Okay, so sample collected properly, off it goes to the lab. This is where the story really starts to unfold, right? And often the first big panel is the hemogram, or CBC.
The hemogram, yeah, or complete blood count, the CBC. It's really a powerhouse test. It gives you a snapshot of all the main components floating around in your blood, your red blood cells, your white blood cells, and your platelets. It's super fundamental, gives a broad look at your overall health, and can flag up a huge range of issues, from simple infections or anemia right through to more complex stuff.
Okay, let's dive into anemia first. When we see hemoglobin, red blood cell count, hematocrit on that report, what are we looking at?
Right, those are your primary indicators for anemia. Hemoglobin, that's the protein inside your red blood cells, the one that actually carries oxygen. It contains iron.
Mhm.
So if your hemoglobin's low, your body just isn't getting the oxygen it needs. That's why you feel tired with anemia. Normal ranges are roughly 12-17 grams per 100 milliliters for men, 11-15 for women. Red blood cell count is just the number of red cells, and hematocrit, sometimes called packed cell volume or PCV, is the proportion of your blood volume that's actually made up of red blood cells. Low levels across these generally point towards anemia. High levels could mean dehydration, or sometimes conditions where your body makes too many red cells, like polycythemia vera, or even just living at high altitude.
Now, you mentioned something called red blood cell indices. This is where it gets really interesting, you said.
Yeah.
How do these help?
Ah, yes, the indices. This is where we start figuring out the type of anemia, which is crucial for treatment. The big one is the MCV, or mean corpuscular volume. It tells you the average size of your red blood cells. So if the MCV is low, the cells are small. That's microcytic anemia, often caused by iron deficiency. If the MCV is normal, it's normocytic. If it's high, the cells are larger than normal. That's macrocytic anemia, which you often see with, say, vitamin B12 or folate deficiency. Just that one number, the MCV, gives doctors a huge clue about where to look next for the cause. There are other indices too, like MCH and MCHC, that look at hemoglobin content and concentration within the cells, adding more detail.
And the CBC also tells us about infection, right?
Right.
Through the white blood cell count.
Exactly. Your white blood cell count, or WBC count, reflects your body's immune army. A typical normal range is about 4,500 to 10,500 cells per cubic millimeter. If that number shoots up, it's often a sign your body's fighting something, usually an infection. Very high levels might suggest something like leukemia, though that's less common. If the count is low, it could mean your immune system is suppressed, maybe from medication or certain conditions. But the real detail comes from the differential count. This breaks down the WBCs into their 5 main types. For instance, high neutrophils often point to an acute bacterial infection. High lymphocytes might suggest a viral infection or something more chronic, maybe even autoimmune issues. High eosinophils are often linked to allergies or parasitic infections. Each type tells part of the story.
Okay. And then there are the coagulation tests.
Yeah.
Measuring how fast blood clots, which is obviously a critical balance.
The very critical balance, yeah. We have some non-specific tests first, like bleeding time, how long it takes a standardized small cut to start bleeding, checking platelet function, and clotting time, which sees how long blood takes to clot in a test tube. But the more specific tests are key. Platelet count tells you how many platelets you actually have. Normal is roughly 150,000 to 350,000 per cubic millimeter. Low count means risk of bleeding. Then you have PTT, or APTT, and PT, prothrombin time. These measure different parts of the complex sequence of protein interactions, the coagulation cascade that makes blood clot. PTT looks at the intrinsic and common pathways. It's prolonged in conditions like hemophilia or severe liver disease. PT looks at the extrinsic and common pathways, affected by things like warfarin therapy or vitamin K deficiency.
And the INR. Why was that introduced?
The INR, International Normalized Ratio. It was developed because PT results could vary quite a bit between different labs using different reagents. The INR standardizes the PT results so a doctor anywhere can interpret it the same way, which is vital for managing patients on blood thinners like warfarin. A normal INR for someone not on anticoagulants is usually up to about 1.3.
Now, what's fascinating here is the D-dimer test. You mentioned it doesn't confirm a clot, but it can rule one out.
That's its unique value, exactly. D-dimer is different. It measures a specific breakdown product that's formed when a blood clot dissolves. So if your body isn't breaking down any significant clots, your D-dimer level will be low. A value below a certain cutoff, usually around 500 nanograms per milliliter, makes the presence of a significant clot, like a DVT, deep vein thrombosis, or PE, pulmonary embolism, highly unlikely. It's
Wow.
incredibly useful in emergency settings, for instance. A negative D-dimer can help doctors confidently rule out those conditions and avoid further, sometimes invasive testing. It doesn't confirm a clot if it's high, though, as other things can raise it, like inflammation or surgery.
And sticking with blood, we have blood grouping and typing ABO and RH. This is critical for a couple of major reasons, isn't it?
Absolutely crucial. The first, obviously, is for safe blood transfusions. Your blood type, AB, or O, is determined by specific antigens, markers on the surface of your red blood cells. Your plasma contains antibodies against the antigens you don't have. If you get a transfusion with blood that has antigens your antibodies recognize, your immune system attacks those transfused cells. It's called a hemolytic transfusion reaction, and it can be fatal. So matching ABO groups is paramount.
And the RH factor.
Yes, the Rh factor is another antigen, RhD. You're either Rh positive, you have it, or Rh negative, you don't. This is the second critical reason: pregnancy. If an Rh negative mother carries an Rh positive baby, her body might see the baby's Rh positive cells as foreign and create antibodies against them. This usually isn't a problem for the first pregnancy, but in subsequent Rh positive pregnancies, those maternal antibodies can cross the placenta and attack the baby's red blood cells, causing hemolytic disease of the newborn. We now have ways to prevent this, like RoJam injections, but knowing the Rh types is the first step.
Okay, so blood tells a massive story. But lab reports obviously cover more than just blood. What about tests that focus on specific organs or conditions?
Exactly. We move into areas like endocrine function, and a huge one here is diabetes markers. These are vital not just for diagnosing diabetes, but also for closely monitoring how well it's being managed day to day and long term. You have random blood sugar, RBS, just to check at any time, often used in emergencies. A level over 200 milligdl is highly suggestive of diabetes. Fasting blood sugar, FBS, is more standard for diagnosis. You fast for at least 8 hours, then have the test. Normal is generally 70-99 milligdl. 126 milligdl or higher on two separate occasions usually means diabetes.
And after eating?
That's the postprandial blood sugar, PPS. Typically checked 2 hours after starting a meal. It shows how well your body, specifically your insulin, handles a glucose load. Over 140 milligdl might indicate impaired glucose tolerance or diabetes. There's also the oral glucose tolerance test, OGTT, where you drink a sugary drink and have blood sugar checked over time. Used less often now for routine diagnosis, but still important for gestational diabetes during pregnancy or confirming prediabetes.
But the real key for long-term management seems to be the glycosylated hemoglobin, HbA1c. What's the practical takeaway for listeners seeing that number? Why is it such a game changer?
The HbA1c is, it's incredibly powerful because instead of just showing your blood sugar at one single moment like the other tests, it gives you an average picture of your blood glucose control over the previous 2 to 3 months.
How does it do that?
Well, glucose in your blood naturally sticks to the hemoglobin protein inside your red blood cells, and once it's stuck, it stays there for the life of the red blood cell, which is about 120 days. So the HbA1c percentage reflects how much glucose has become attached over that period. It's like a long-term average. Normal is typically below 5.7%. Prediabetes is often 5.7% to 6.4%. And 6.5% or higher generally diagnoses diabetes. For someone managing diabetes, it's the key marker doctors use to see if the treatment plan is working effectively over time.